Hello, this is Anne DeGheest. This is Friday, August the 28th. This is Anne Insights, and this is my second video on clinical insights. Tim, one of our participants on YouTube, has been wonderful. He took all my videos and he created a PDF that keeps tracks of all the time index for every video on exactly what the different subjects are. He also put together another PDF that has a link with every type of subject that's being done alphabetically there. I will put a link of all these videos on the description of every video. So this is really helpful for people trying to say, when did we talk about masks? When did we talk about catching COVID and infection rate and all of that? So you may not know, but we have been burned out in California. We have 15,000 firefighters who basically, we had a massive amount of lightning strikes, 14,000 lightning strikes that hit the ground. 2 weeks ago, they created 700 wildfires, 1.3 million acres burned. We were just next to the evacuation warning zone, so we had to get ourselves ready last weekend there. And the air is so toxic, it's gone as high as 200 to 300. So really a bad situation here, which gives some perspective about COVID, which is we have to manage both of them. So let's do a quick update on the clinical side. I'm going to compare a COVID versus SARS versus flu. I got multiple requests from people who've been watching the videos of trying to kind of do a recap of the difference between that. There's some update on the long-term damage and long haulers, the risk of reinfection. 2 cases now have just come up on reinfection rate. So we'll do a quick deep dive on a few subjects. So this is an image of 102 years ago. This is when there was the Spanish flu. Things haven't changed much. In fact, that person here still has the mask under their nose. Please put the mask above your nose. Otherwise, it doesn't really help. So I just was trying to get perspective about how much healthcare has improved. Just kidding. So quick recap is that we know that mass social distancing and hand washing work. In fact, we discussed last week that as a result of that, the flu in the southern hemisphere is not there because people are not contagious with the flu because of the protection they're doing with COVID. We know that children may have a lower chance of being very, very sick, but they are as contagious. And we saw, in fact, a couple of weeks ago that the younger children, they are less than 9 years old, are significantly more contagious than the adult. We're doing a much better job in managing this. The 20% of people end up in the hospital there because of cytokine storm. That's why the mortality rate has gone down in the US. It's confirmed over and over again that on the average, asymptomatic has 40 to 50%. That's important because we're going to talk about the new CDC guidelines, which don't make any sense. Indoor transmission is 20 times 20 times worse than outdoor transmission. We know there was a mutation of the virus in March, and we're going to talk about that people are getting reinfected with a different virus. So we need to keep track of these viruses there because they are infecting people who had antibodies. And we know that pre-existing condition is what drive the outcomes. And a key important thing, this virus is spreading by super spreading events, which is very different than SARS and the flu. So what we don't know is when we get a vaccine, and I'll talk today about the fact it's being politicized, and therefore we need to be very careful that the vaccines don't get approved for political reasons, but because they're safe and effective and durable. So please take a look at my July 31st video when we did a deep dive on all the different symptoms of the virus, but at the high level there, the loss of taste and smell is unique to this disease. If you have that, it's the first symptom. Around 67% of people have that as the first symptoms there. We also spent quite a bit of time on the August 14 video reviewing the immune system. And so I will talk about the T cells is what's becoming even more important than the B cells. The B cells is what we found were the antibodies, and we're discovering they don't last very, very long. And where the T cells are more specific, and if you have been exposed to common cold in the past, which is a third of the common colds are coronavirus types, you may develop some type of response. And we find out that in Europe, they've done studies showing a third of the people in Holland and 20%, a third of the people in Germany and 20% of people in the Netherlands, and up to 50% of people in Singapore, because they're closer to the bad area there in East Asia there, have some type of protection. That means they still get infected, but they don't have the same severity there. So if you want to learn more about that, take a look at my August 14 video. Let's talk about the long haulers. Again, we did a deep dive on this on August the 21st and August the 14th, but there's some new information that just came out. So just a reminder, the virus, really big impact may not be mortality. The really big problem is going to be the fact that 30 to 50% of people may have long-term problems. And the CDC is estimating that right now, 30%, regardless of the severity of your symptoms. So people with mild symptoms may have long-term problems. It's not just linked to people in the hospitals there, and it's across all ages. And it goes into respiratory problem with damages that you can see in X-ray and CT scan. People who have cardiac damages in their heart, and inflammations in the heart. And you can see the number is stunning, like 36 to 46% of people in Wuhan had neurological symptoms. And then the one that everybody has is chronic fatigue, exhaustion, that can barely go up the stairs. So if you haven't heard about this yet, please check my 2 videos there. The latest update is, first data is showing that the virus goes deep inside the cardiac cells, and it goes in what's called the myocytes. And they've now done autopsy of people who die from congestive heart failures as young people there, and then discovered that that virus is deep within the cells, within the heart. And so that's very important there, because if we look at SARS in 2003, which is the closest cousin to this COVID, 40% of those patients, they develop cardiac abnormalities. So it's going to be important there. If you are a survivor of COVID, even if you were mild, and if you have any type of symptoms of cardiac arrhythmia and all of that, please get yourself checked, because it's pretty clear that we may end up with some similar type of statistics, which is stunning, because this is affecting not only severe patients, but mild patients. The bad news is that when these people go to the doctors don't believe them. And they don't believe them because every doctor is usually specialized. And remember, this is multi-organs, and everybody's slightly different. There was a study that was done by the Body Politic COVID online support group, which is self-organized over the last month there. And what they showed is that 23% of the people who are these long haulers, who have these symptoms after several months, only 23% had positive COVID test. Half of them were never tested because at that time, which I'm talking March and April, that was the first wave, the criteria was very tight. You could only be tested if you had gone to China or if you knew somebody was infected. So a lot of these people didn't get tested. And even 28% of these patients got tested negative. Because again, it depends when you do the testing. You know, there's a period there for the PCR, which is probably between 3 days after infection to maybe 21 days after infection, that the PCR is going to capture your viral load. But if you do it before or after there, your test may be false negative. And this is all a consequence of the inadequate testing within the US. So the problem is that these people are coming up with these really wild symptoms, and the physician says, well, you know, you never got tested for it, and therefore, you know, I don't believe you there. The other problem is that a lot of the antibody tests, and we discussed this in the past, are not reliable. There was a long list of tests that were approved by the FDA on an emergency basis there, and those tests have been shown to be up to 30% inaccurate. So it's a very big issue there. And then to put one more thing into the pot here, a study came out showing that your amount of antibodies, which remember we know can be declining after 3 to 4 months, is a function of the severity level that you had, which makes sense. And so if people start getting symptoms 2 to 3 months later and you do an antibody test, they may not have antibodies anymore, even if they had been exposed to the disease. So that's why we're starting to see this rehab center being created like in New York, and then the support group there to just say, please take me seriously, because if we take 5 million people who've been exposed and multiply by this by 30 to 40%, these are millions of people that are going to need care. Reinfection, good news and bad news. So there was a person in Hong Kong that was 33 years old, and he has now been infected twice. He was hospitalized in March with a positive PCR test. He was discharged after 2 negative tests, which is the criteria, in April. He went to Spain. Remember what I told you about Spain? Don't go there, please. And he went back to Hong Kong. In Hong Kong at the airport, they test everybody because they're trying to control any reinfection rate. And he discovered he was positive, and he was asymptomatic. That was the good news. So he did not know he was he was a carrier. And they did a full genome of the virus the first time and the second time, and they're two different lineage. The first one was from China, and the one he picked up, guess what, is the European strain. So questions, we don't know yet. Because he had prior antibody, does that mean he had a less severe reaction? And number two, was it contagious? And remember, we don't have a good way of testing if you're contagious. When we do a PCR test, we know if you have the pieces of the virus there. We don't know if it's active or passive. That's very hard to do. The news that just came out literally half an hour ago is that we may have the first US cases of a 25-year-old, so remember, these are young people there, in Nevada. He had a mild case in April. He tested negative twice. He was never hospitalized. He just had a mild case. And he ended up with a second case at the end of May and ended up being hospitalized in June with oxygen and being very severe. So again, they did the genome analysis and he had two different viruses. Now, the good news, it's only 2 cases out of 25 million cases. But that means that if the virus mutates enough, that the antibodies you have, and it is enough time period there, these are short period of time, it's only 2 to 3 months before they pick between the first and second case. So we need to keep an eye on that because that has issues about vaccinations and lots of issues about how we control this virus. So I was asked to kind of do a recap. Well, this is like a big flu. What's the big deal? Why are we doing all these things to the economy? So I just want to compare things. So the coronavirus started in December 2019, and I suspect it's going to last to 2022. The SARS was only for a short period of time. So far, we've had 25 million people worldwide and 6 million in the US. SARS had only 8,000 people and only 8 people in the US. To give you some idea there. Let's compare this to the flu. Pretty much the flu, a third of the coronavirus are related to the flu. A third of the common colds are related to the coronavirus. On the average, there's around 35 million cases in the US of the flu. And I take the 2018, 2019, this is CDC data. Here's the big difference. When you have the flu, you pretty much have symptoms very, very quickly there within 24 to 48 hours. And you're only contagious for a short period of time, and you're contagious while you have the symptoms. So most people stay at home and they don't infect everybody around them. The problem with COVID is that 100% of people are pre-symptomatic, and that could be between 1 to 14 days, on average between 2 to 5 days. And then 30 to 50% of people are asymptomatic. That means you have a very high percent of the population there that's contagious that doesn't know and is spreading it around. When in the case of the flu, most people know they have the flu very quickly there and then take care of themselves and stay at home. The SARS had a much shorter incubation. You basically were contagious during maybe 2 to 7 days as opposed to COVID, which is a much longer period of time. They were all having aerosols, as a way to contaminate. The flu had bigger droplets. To give you an idea of the mortality rate, 833,000 people have died, 181,000 in the US. And in the flu season, it's between 12 to 61,000 people. 61,000 was this very bad flu we had a few years ago. On the average, it's maybe 30,000. So just on the mortality rate here, you can see that we are now a factor of probably a 5 to 6x, depending which factor you use there. Fatality rate is 4.7% worldwide. It's between 1.8%, which may be what the US is, to 11% in Italy there. SARS was 11%. The flu is 0.1%. So that's a big difference there. Symptoms, it's everywhere in the body. And we talk about the long haulers, which means this could be 32% of the population may have long-term damage. Pretty much the flu is mild upper respiratory there, and most people, 99% of people recover without any long-term problems there. Reproduction rate is 2.2 versus 0.9 to 2.1. So clearly this is much more contagious there. And this is one of the difference. The COVID, we talk about this several times, it's a super spreading event. You can have one person, one event that contaminated like hundreds of people there, where the SARS, the traditional SARS and the flu is one-on-one. You literally meet one person who passes it on to somebody there, and it's usually close contacts. It's somebody that's like within 3 to 6 feet. It's in a classroom, it's at the office, or it's at home. And it is expected the attack rate, as they call it, up to 40% of the world will be contaminated with COVID at some time in the future there, where on the average, the flu is maybe 8%, between 3 to 11%. And of course, SARS was kind of not really noticeable just because it was a small thing. So again, I'd like to emphasize COVID is the real thing, and this is not another type of flu. It's a big, big difference there. So I hope that helped. Another way to look at this is the mortality rate. If you look at the flu, it's really very low mortality rate, except for people slightly over the age of 65. If you look at COVID, look at the mortality for 85 years old, it's 10%. And pretty much it's a significantly more of a killer for the older population there. So flu, no, it's not. Please use this data for people who still think it's just a flu. Viral load. So this data shows, and it was published in the Lancet, that the quantity of viral exposure correlate with severity of the illness, which makes common sense. The more virus you have inside your body, the higher is your chance that your body gets overwhelmed and you have more severe symptoms. And they did this analysis there showing that if you look at the alive patient, people who survive, this was the number of copies they had per milliliter, which is the way they did the PCR test, so 5.2. And the people who die had 6.4. And there was clearly a direct correlation with the amount of viral load. So there was direct correlation between how much viral load you have versus severity. And that's important there because remember, the viral load is a function about who you get exposed to, how much they give you the viral load, how often, and for how long. So they published what's called a hazard ratio. Hazard ratio means if you have a ratio of 1, which is that dotted line here, that means that you have the same risk. And clearly having a viral load is directly correlated with a more severe outcome there. But the other one that shows is coronary artery diseases was also correlated with that. This is this one here. You can see it's really high up, one of the highest one there. COPD, which is cardiac obstruction of the pulmonary disease there. People with diabetes, heart failures, and being Black. Ironically, the Asian population has a lower risk. That may be due to lower amount of pre-existing condition that you will have in other populations. Let's talk therefore about aerosols, just as a reminder. So there is 3 different types of aerosols. There is respirable aerosol. These are the tiny, tiny particles. These are the ones that stays in the air for a long period of time. And they are tied to humidity. Remember, if you have very high relative humidity there, the virus gets this big water around it. And so therefore it falls to the ground faster. If it's low relative humidity, it gets to be really, really small. Therefore, it floats in the air longer. So it's really important that you understand that there's a relationship between the environment you're in and the danger of this virus to stay in the air for a long period of time. And you have what's called the thoracic aerosol, which are bigger particles there. They are 10 to 15 microns. And then the inhalable aerosol, which are this big one, that's the 3 to 6 feet. These are the ones that kind of drop into the floor. Now, the data is pretty clear that if you're wearing masks, you really drastically decrease the big thing, the big particles. And then most of the masks, they work at 2.5 to 5 microns. And you may still have some escape because it's not a tight seal there, but it's in a short area there. So it's really important that you wear a mask. So let's talk about aerosol. And so if you're infected there, you have things that drop on the floor, and these are called the fomites. And pretty much you should assume most of the floors are contaminated if you go to stores or if you go to restaurants. So watch out for your shoes. Please don't bring your shoes back into the home or basically disinfect them when you come home. And then you have the issue of close contact, which is the airborne particle there. And if you get some distance there, they may fall on objects, but they may not go into the air. So let's kind of do a bit of a deep dive on that. So what's called fomite, which are objects that gets contaminated, that include your skin. And the good news is that there's a lipid envelope around the virus, and the lipid envelope doesn't like to be on skin and hands. It kind of breaks apart. So it doesn't last very long there. So initially we found that a lot of the contamination was due to objects or by the droplets dropping on things. Now we believe it's a low chance of infection. The droplets move like bullets. I mean, they literally visualize like a bullet on a cannonball is what I said somewhere. And it basically ends up somewhere. So it hit your face, so it's the walls, or it drops in the ground, okay? And then this is the one we discover is kind of the big problem, is the aerosol and the airborne. And these are, think about like a smoke. The particles are so small, they're floating in the air and they disperse through the air. And that's the one you have a very high risk of inhalation there. To give you an idea, it's perceived that outdoor is 20 times safer than indoors, because indoor, the smoke stays inside. You all have burned something, like my husband does once in a while, he burns the toast, and basically the smoke stays in that room for a long period of time. We also know that if you talk, if you sing, or if you shout, you increase your aerosol by a factor of 10 to 50x. And if you're in close proximity of somebody for 15 minutes, you have a very high risk of contagion. And please look at some of our prior videos there. We got some really nice analysis there, or how much time you need to be exposed to somebody to a risk of contagious there. So the idea is to avoid indoor, crowded, poorly ventilated, long duration, close proximity, and any person that has an unmasked fitted mask. If you see somebody and their nose is above it, or it's kind of loose and goosey and hanging over their neck, stay away. Ventilation is getting to be really, really more important. Every week we look at this. Open your windows, unless you're in California, and then you basically get smoked to death. Have a very high air conditioning filters. Try to bring HEPA filters. We have HEPA filters all throughout our house right now. Some people have put germicidal UV into their air ducts to basically damage that in bigger building. Look at the circulation rate, increase the air circulation rate. Most of the building have a low circulation rate. And you can very easily put portable HEPA filter. This is what we did in our house. We've bought several HEPA filters all throughout the house. So let's look at influenza. Influenza, is basically very much a short period of time there. The SARS has -3 days. This is the time you get exposed, and you can have up to 3 days. So it's really the peak of the viral loads before you even know you may have any symptoms. And that's the problem with that disease, is that is when everybody gets infected there. And that's assuming you have symptoms, because remember, another 50% are asymptomatics there. So that's the big difference with the flu, is that most people, they get symptoms very quickly there, and then the time of infection is very short. So again, it's not the flu. I got this really interesting article from one of our viewers there, and he's a musician. And they did this analysis to say, what happened if you're a musician? And we all know that as you're breathing, you generate some particles, and this is the size of the particles there. If you talk, you get bigger droplets. If you sneeze and cough, this is like cannonballs and bullets going. It's like at 200 miles per hour at times. And then what happens when you play a bassoon? I thought that was interesting. So they did an analysis of 24 masks. And we have shown this several times over the last few weeks, that the mask you have can be really dangerous if you don't know what you're doing. And you can see that the fraction of the collected mask there is all over the map between these masks. Most of the masks were not really effective in these small particles there. They were stopping really big one, the big droplets there. But the one we really worry about is this tiny aerosol that floats in the air for a long period of time. So as a rule of thumb, try to get an N95 or surgical mask, and some of this mask, it's, are not really that effective. So then they look at single masks. So the good news, if you have a mask, it's still very low contagious as opposed to having no mask, because these people are really singing out, so they're really throwing out these droplets in the air. But then they looked at most of the masks that people were using were really ineffective. And remember, we're trying to stop this area here, which is the aerosol. The aerosol are all these tiny particles there. So, please look at prior videos there when we spend quite a bit of time on the effectiveness of masks there. But, pay attention. A mask is not a mask, is not a mask. So the other news they did is that if you wash it 3 times, and these are the filter layer mask, it loses its protection. And so you had this very high level MERV 13 filter layer, really kind of, match number 4 in their analysis there. You wash it 3 times, and it's laterally dropping its capacity of stopping the aerosols. And of course, we all know you need 3-ply the minimum, because the 2-ply don't really do too much. So really be careful there. So here's the interesting part. If you do a bassoon, that's the worst. If you play the piccolo, which would make some sense, that's the best one that's creating particles there. And then the French horn and the oboe, you're really blowing a lot of air out there, as well as the saxophone. So these are based on particles over 0.3 microns. So they probably could not, it's very hard to measure less than 0.3 microns. So if you're if musicians there, try the piccolo instead of the bassoon. Just kidding. So let's talk about ventilation. University of Minnesota did a computer stimulation. So I emphasize it's computer stimulation as opposed to full body analysis. With a person that had no mask. And they look at the classroom setup. And this is, I'm going to go slowly on this because it's reverse logic. What they discover is that if you have the air conditioning on the side above the head of the person there that's contaminated, there's a vortex from the air ventilation system there that keeps the droplets in that area there. It doesn't push it this way, which is what you would have expected there. If on the other hand, you have the air conditioning across the room from where the person is, so the flow is going this way, the vortex is such that it basically blows the air and recirculate the air and therefore contaminate the whole room. And so this is important for classroom there because we have to really look about where they have put the air conditioning system. And of course, things get complicated because a lot of these air conditioning rooms, they may have two systems there. So we have to do some analysis of the classroom there. And after 50 minutes, only 10% of the aerosol were filtered out. That means most of them were on the walls and the floors. So again, I go back, the floor is really something we need to get more aware of. They had an analysis of grocery stores. In the grocery stores, because there is all this shelf, it acts like a tunnel. So ironically, it's much more effective at basically getting the air circulated there. And in their cases, they found that 50% of the particles, I'm missing an S, were vented out. So we're going to learn more, and hopefully there's going to be more analysis there because clearly circulation, as long as you don't have wildfires outside, is essential. So we need faster at-home testing. We talked about this. We need to get away from these PCR Cadillac models to do rapid testing because what's happening right now is that this is your viral load. I remember it takes a few days and you have to make sure you get tested during this period there so we can detect it. And right now, if we do a PCR testing and it takes 4 to 5 days to get the results, it's pretty much useless. What we need is to do a lot of testing over here on a surveillance basis. People are pre-symptomatic or asymptomatic, and we do this several times a week. Therefore, we need rapid testing, and we don't want to get somebody that's ultra precise like the PCR here. We need something that's good enough because the viral load are so big. We don't want to have the sensitivity that detects this. We want to get the sensitivity that's good enough to detect people who are contagious in a very quick way. So rapid testing is critical. In the best of all worlds, we like to do it every day. If we could do rapid testing every day, for the sake of discussion there, we could really stop the spread of the infection. If we do it once every 3 days, it still works pretty well. But if we have the hypersensitive PCR, which is once per week with a 2-day delay, which is still better than what we're doing today, you can see that we can't control the virus. So it is really essential for us to have this. So the good news is Abbott just was approved this week under an emergency approval by the FDA for a new $5 antigen test. Now, antigen is not looking at like PCR is as the presence of the virus. It's looking at the protein that you're making in your body as a response to the virus being in your body there. Good news, it's $5, rapid response. It can measure the protein within 7 days of symptoms. So the bad news is that it doesn't do anything for pre-symptomatic. That means you have to get some symptoms, and the other 40 to 50% were asymptomatic. They have only been approved for people who have symptoms. You still have to do a nasal swab, so it has to be done by a healthcare professional, so it's not a do-it-yourself at home. And it's kind of a similar technology to the home pregnancy test. So you can see it basically tells you yes or no. It's what's called a home lateral flow. It's the size of a credit card, so it's easy to use. And the US just bought 150 million tests for $750 million a few days ago. It has pretty good sensitivity, which is what you're looking for. There's 2 other companies called Quintel and Becton Dickinson who have also an antigen test, but they're totally overwhelmed by the demand, and they're not able to provide enough of those. So hopefully Abbott, who's a very big company, is there, can start filling up some of that demand. As a result of that, the government is going to be shipping 11,000 point-of-care antigen tests to nursing home, and they're using Becton Dickinson and Quidel, which are the 2 have been approved. And they only want to do it for people who have symptoms. Again, it's not being recommended for asymptomatic, which is 50% of the population there. It has to be done within 5 days of the first symptoms. So there's a time window there. And they have a high Becton Dickinson as a 15% false negative, which means if you're negative, you don't really know if you're truly negative. So that's still a bit high. And therefore, you still have to do a PCR if you have other clinical symptoms. They're going to give every nursing home 150 to 900 free tests. So that's good news. But then they have to pay for it afterwards. And 150 to 900 free tests won't last very long if you have 100 residents per nursing home. And then the guidelines is that if your positive rate is 5%, you need to do a weekly test. So the issue is who is going to pay for this, because most of the nursing homes don't have a budget for this. In addition, different states have different regulations. So for example, California, Illinois, Maryland, and Massachusetts require PCR. They don't trust the antigen, so make things complicated. I'm not going to do a deep dive on treatment. If you're interested there, we did a very deep dive on August the 7th. I highly recommend there. This is a great overview in all the different therapy, if you have COVID, that have been accepted, the one that are promising, and the one that are coming up. A quick update is convalescent plasma. So convalescent plasma was all over the news this week. So we take the blood from survivors, we spin it, and we extract what's called the plasma. Already 60,000 people have received plasma, so it has been widely used. There was a big hoopla this week because on August the 19th, the FDA made a decision not to approve convalescent plasma. It was put on hold. Dr. Fauci, who is our top infection control in this country, and Francis Collins, who is the head of the NIH, basically said there's not data that is good enough to show potential benefits. And that's because the Mayo Clinic did a study of 35,000 participants, but they had no placebo control. They had nothing to compare to. And then the only thing they show is that a difference of 1 day. So if you give convalescent plasma within 3 days of a diagnosis, not of first symptoms, not of exposure, but of diagnosis, which is different from person to person, versus somebody who gets it after 4 days, you had a difference of between 8.7% and 11.9%. This number is important. I'll tell you why in a few minutes there, because that's a 35% drop in relative risk. But that's only a 1 day difference, and there was no control group that you could compare to. So it was perceived by these experts, it was not groundbreaking. The next day, the White House went on a full attack of the FDA, saying that, and I'm quoting this, FDA was part of a deep state, it's delaying the trials, and any type of approval of vaccines before the upcoming presidential election. And this is important there because we need to make sure the FDA is trustworthy. On Sunday, so after 2 days of the attack that were directly going at the FDA commissioner, which was Stephen Hahn, was appointed by Trump, is that the FDA reversed themselves and they approved it. And I'll talk more about that in a second there. In addition to that, the World Health Organization on Monday, on the 24th, cautioned against the use of blood plasma for COVID survivor. In their mind, there's not enough conclusive data, and it should not be a new standard of care. So let's take a bit bigger dive. The issue there is that, can we trust the FDA? Is the FDA truly independent, which was what they have built their credibility for the last 20 years? There was this 3-day reversal there. In addition to that, Stephen Hahn, who is the FDA commissioner, when he was talking next to Trump on Sunday, erroneously said that this will save 35% of life. He said, out of 100 people with the disease in the hospitals there, we could save 35 lives. That is incorrect and misleading. It's a relative 35%. Remember what I said earlier, from 11.9 to 8% there. And then everybody went crazy. All the experts in the US basically asked him to resign and to also correct the fact that he made a mistake, which he did at the end of a very long series of tweets. And at this moment there, people have now lost credibility that Stephen Hahn can really, am I going to say this politely, can basically put up with the pressure he's going to get in the next 3 months to get a vaccine approved. And so that's a big concern there, because we need to trust the 3 pillars of healthcare, which is the CDC, the FDA, and HHS. And in the last few months, all 3 of them have lost tremendous credibility. The CDC, if you remember, they made this faulty virus test in February, and then they tried to pressure the FDA to stop the approval of other tests that other people were developing in the private sector. You had this massive, bizarre thing that happened this week where the CDC, under White House pressure, changed the guidelines on how we should do testing. I repeat that. It was said it came from the top down, from the White House. Fauci was under general anesthesia doing surgery. They claimed Fauci had agreed to that. The poor guy was under general anesthesia. He was not involved. He had nothing to do with it. And it means that we do not test asymptomatic patients, even if they have been exposed to an infected person at close contact, which doesn't make any sense because we know 40% of infections are asymptomatic. And that's against the political perception that less testing means less cases, better election. So there's a huge backlash. California has decided it will not follow the guideline of the CDC. Most of the healthcare providers announced today in a large system they will not follow the CDC. And that's really bad news because we need somebody we trust that's an independent healthcare experts. And the CDC was that. They made some mistakes in February, but now we have lost credibility with this new CDC guideline on testing. The FDA last week, we just talked about, made a false claim on saving life, which was repeated by the head of HHS. So he took it away, but it basically was kind of an issue there. In addition to that, we talk about HHS under the White House that basically tried to collect all the data, and all the number of cases in the US went straight down after they collected the data. So even if it's a coincidence, we know there was 1 week of delay and chaos in all of these other things, and now they're returning confirmation back to the CDC. So in a period of a couple of months, we pretty much have lost credibility in the 3 pillars we need to feel safe when the vaccine comes out. And that is, in my mind, a very big concern. Personally, I will now have to look at the detail of the clinical trials to really be able to judge if this vaccine, which are going to be approved very quickly there, are going to be something that I want to take the chance on. But how can other Americans look at this data and really be able to make an evaluation? To make things even more complicated, China has approved, and we talked about this on August the 14th, their own vaccine with barely any testing. And in fact, the testing that was done in Canada showed 9% severe adverse events, which is significant for a vaccine. And so what they're really doing is a public vaccination testing of their population there, especially their military there. They are in the process of selling this vaccine to developing countries. So that's very worrisome too. Last week, there was an interesting incident in Papua New Guinea. There was an airplane coming with Chinese workers to work in the mines. And they were told that all those people in the airplane had been vaccinated with the new vaccine from China. And they forced the plane to turn around because they did not trust that these people were truly protected. So we're going to hear more about that. As you know, Russia had now the Sputnik 5, which barely had 20 to 30 people were tested. They're doing testing in the Philippines and the UAE. And they're basically launching public vaccination without any phase 3 trials. So the politicization of vaccine is very worrisome there because we want to make sure we don't vaccinate 7 billion people with something that hasn't been fully tested. So keep an eye on that, and we're going to continue to basically talk about this. New activities, where are people spending their time? Surprise, surprise, unless you're in a wildfire country, people spend more time outdoors, in the parks, and walking around, and more into their house. And of course, less time at work, still minus 37% of people, a third of the people are not working in an office. And of course, you can see a drop in retail and of course, public transportations. I've said this every month. It's very concerning that student anxiety, especially as they're going back to these online classes, there is going to be a massive issue there. The data is stunning there. 52% are classified as depressive. Some people seriously consider suicide, 25% of the 18 to 24 years old. So if you do have kids or grandkids in that age group, please communicate with them because you need to really keep an eye. People are having a hard time dealing with all the stress right now. As a result of that, school and colleges are offering mental health apps like Calm and Headspace and Journal Meditation. They're using telehealth like Timely MD on campus to basically help people express their anxiety there. And unfortunately, on the colleges and the school, there's huge resistance not to betray your buddies. And so people refuse to share information on contact tracing. And a lot of these colleges try to deploy these contact tracing apps with people are not willing to share the fact they went to a party, which that was probably illegal on the campus, or they're going to bars. So we're having a problem reaching out to that population. So please reach out if you have loved ones and educate your family about this. So I want to thank you for listening there. Remember, we're going to move to bi-weekly there, so we won't be here for next Labor Day weekend. And please take a look at my first video on the virus and some good news for the US. Thank you and see you in 2 weeks.